Today, we're going to hurt somebody. I'm only kidding a little bit. So, welcome to PM Rounds, a podcast exploring the wonderful world of medicine and healthcare. My name is Chris, an internal medicine resident, and I am your host for today. And we are going to discuss a really exciting topic that I absolutely love talking about on the wards. This is sodium bicarb and its routine use in cardiac arrest. This is an extremely hot topic, very controversial. So, we're going to have a lot of fun with this today. My goal is simple. Okay, on this show, PM Rounds, I want to take complex medical topics and turn them into a format that's entertaining, educational, and something that we can have a lot of fun with. So before we get into it, a little disclaimer.
Of course, this podcast is an independent production. The views and opinions expressed here are my own and those of my guests and do not represent the views of my residency program, any hospital, affiliated institutions, or employers. This content is intended for educational purposes only and should not be considered medical advice. Clinical decisions should always be made based on individual patient circumstances, institutional protocols, and in consultation with appropriate medical professionals.
In other words, I don't know anything. Don't listen to me. This podcast is for entertainment and educational purposes only. With that said, let's get into it. All right, so today we are discussing the role of sodium bicarb during cardiac arrest, a therapy that has really dramatically evolved over the decades. To get to the heart of this topic, let's first start with the background. So sodium bicarb in cardiac arrest, why do we do it? So we give sodium bicarb, which is basically just baking soda. We give it IV basically to raise the pH of the serum. All right, so the core thing here is that the body was designed to work at a certain pH, that perfect 7.4 that we like to see on our ABGs. And that if we deviate too much from that ideal pH, that's a bad thing, which is fair. We see that, in our patients in the ICU, the patients who are in septic shock, who are post-cardiac arrest, our sickest patients, they tend to be more acidotic, and we have grown to associate acidosis with basically poor patient outcomes, right? And in theory, this makes sense on a physiological level, right? So acidosis impairs cardiac contractility. That's an argument that's made. Acidosis causes arterial vasodilation. All right, it causes our vessels to basically, loosen up. It causes our blood pressure to drop, and it causes decreased response to catecholamines and vasopressors, right? So acidosis does all this bad stuff. Acidosis increases risk of arrhythmias, especially post-cardiac arrest. After people have cardiac arrest, it irritates the ventricular myocardium, and then this acidosis can independently increase risk for arrhythmias, especially ventricular arrhythmias like VFib and VTAC, right? So all of these things kind of point to the fact that acidosis is not a good thing, which is fair, right? So cardiac arrest leads to acidosis by a couple of different mechanisms. So, when you take someone who goes into cardiac arrest, okay, you'll get acidosis by basically two different ways. One is through respiratory acidosis, which is the less significant contributor. So you can imagine that during cardiac arrest, there's some degree of hypoventilation, right? Especially in the events leading up to the arrest and prior to intubation. Hypoventilation will lead to CO2 retention. And then if we remember our CO2 and bicarb kind of equilibrium that we have in our body, when you have a buildup of CO2 combines with water, carbonic anhydrase will convert CO2 and water to carbonic acid. And then carbonic acid will then dissociate into bicarbonate and H+ or protons, right? So that's the theory here. So we know that the hypoventilation in the setting of cardiac arrest will lead to a respiratory acidosis to some degree. However, what really drives acidosis in the setting of cardiac arrest is really it's a metabolic acidosis, right? And this makes sense because if we think about what is cardiac arrest is not a ventilation problem. Usually we're able to address the ventilation aspect pretty fast. And, once within a couple minutes of cardiac arrest and doing CPR, usually you can have the patient intubated. And once you're really ventilating them effectively, you can really mimic the job of the lung, like overall pretty well. I'm not saying it's not close to 100%, but it's a lot better than the way CPR is supposed to mimic cardiac function, right? So when we ventilate a patient, we're actually able to, do gas exchange pretty decently. What we don't do decently is mimicking the cardiac output, right? Cardiac arrest is a perfusion problem, not really a ventilation problem. And the reason is because when we're doing chest compressions or whatever, the cardiac output that we can achieve is really only like, it varies, but maybe 10 to 30% of the normal cardiac output. So this is what I want you to conceptualize. Cardiac arrest is a perfusion issue, right? It's a low flow state. It's a state of low blood flow. So as a result, our organs are not being perfused. And even at the cellular level, they're not being perfused either. So then that forces us into, remember, anaerobic respiration. All right, remember we have this thing called glycolysis. It takes sugar and turns it into pyruvate. And then pyruvate can kind of go in two different directions. Either goes to aerobic metabolism, where it very efficiently produces very, very high amounts of energy through the TCA cycle. Or if there's not enough oxygen or the cell's not working properly, it can go through the anaerobic pathway, where it does basically lactic fermentation and it produces lactic and acid. Right? That's why with the state of hypoperfusion, at the cellular level, our cells are starving of oxygen. And then we're producing lactate and producing acid, lactic acidosis, which is a metabolic acidosis. So that's primarily what we see in cardiac arrest. Now let's look into the history of using bicarb in cardiac arrest. Now there's not really one single study that pinpoints when exactly we decided to start using bicarb in cardiac arrest. But really, the big culprit here is that there were several dog studies that were done back in like the 1970s and 80s, and it was actually very unfortunate. They used to, it was typical in like anatomical and research laboratories that they would do a lot of like live animal experiments back then. And so, they would experiment on these dogs. And they basically found that in many of these studies that when they induced cardiac arrest in these dogs by various means, that they had more effective resuscitation with bicarbonate, right? I mean, we can look at, I got a bunch of studies here, and they were doing dog studies really, into the 80s, 90s, and even early 2000s, they were doing some. But, we can look at, one prominent study, and this was a very influential study in terms of popularizing bicarbonate for cardiac arrest. This was a study done by Redding and Pearson back in 1968. This was an early influential study that was done in JAMA, published in JAMA, very good medical journal. And they basically suggested that the combination of epinephrine and sodium bicarbonate was highly effective in restoring circulation, so basically achieving ROSC after 10 minutes of circulatory arrest, with survivors showing better 24-hour outcomes than those receiving other drug therapies, right? So, and then there was this dog study, and there were many others like it, and there's also theoretical and physiological evidence that acidosis was bad, and that bicarb could fix it and improve cardiopulmonary resuscitation. All right, but something that I want you to keep in mind is studies like these back in 1968 were done over 50 years ago now. So these are really old studies. They used resuscitation techniques that are different than they are now, and also drugs and drug dosages that are also different. So for instance, they were using very high dose epinephrine that's no longer standard in modern practice. Not to mention, in this particular study that was done by Redding and Pearson, the arrest was caused by asphyxia rather than primary cardiac issues. And as we know, results from asphyxial arrest do not always translate well to being comparable to other causes of arrest, right, such as VFib or trauma. And they didn't address several other things, such as, risks of hyperosmolality that you get with bicarb, sodium overload, fluid shifts, things like that. So the picture that I'm trying to paint is that we had these, mostly dog studies done in the 60s and 70s, had relatively low sample sizes. They were not done on humans. There was poor experimental technique at doses and CPR techniques that are not really used today and don't really translate well overall into modern practice, especially in arrest and post-arrest care, right? And, we can go through, there's a ton of studies like this, so after this stuff came out in the 60s and 70s, in 1976, sodium bicarb was first included as a first-line treatment for cardiac arrest in ACLS guidelines. So this was big. And it was actually the most frequently used medication, even more frequent than epinephrine, into the mid-1980s. So bicarb was a big deal back then. All right. And then, so we started seeing the cracks in sodium bicarbonate and its utility in cardiac arrest form as early as it was implemented. So even as early as the late 70s, so 1976, there was an article that was published by Bishop and Weisfeld. It's called Sodium Bicarb Administration During Cardiac Arrest, Effect on Arterial pH, PCO2, and Osmolality. All right, so this is when the cracks began to kind of form in the routine sodium bicarb use. This is a direct quote from the article. In the absence of pre-existing acidosis, severe acidosis can be prevented by adequate ventilation alone. Sodium bicarb administration results in a significant rise in PCO2, which parallels the rise in pH despite adequate ventilation. And 3, during the prolonged cardiac arrest and resuscitation, there is a rise in arterial osmolality that is accentuated by sodium bicarbonate. Right? So what is this telling us? Number one, that effective ventilation can in some ways curb the effects of acidosis or blunt the effects of acidosis. That sodium bicarb can increase the levels of PCO2 in the blood, which makes sense because if you think about it, administration of bicarb will result in protons and bicarb being converted to carbonic acid, which will then get converted to H2O and CO2, right? So sodium bicarb can increase your arterial carbon dioxide levels. And that during prolonged arrest, where you're using a lot of bicarb, you see a rise in the osmolality of the blood that's worsened by the administration of sodium bicarbonate. So that was huge. And then, we'll get into why all of these are actually very bad things later. But interestingly, they began to backpedal in terms of the guidelines recommending sodium bicarb as soon as 1980, right? So 1976, bicarb was first included as a first-line treatment for cardiac arrest. Then by 1980, ACLS already started to backpedal, right? So I found one paper, again, this is a JAMA article published August 1st, 1980. It was called Standards and Guidelines for CPR and Emergency Cardiac Care. This is a direct quote. Since the previous standards for CPR and ECC were published, more information has become available on the recommended uses of this drug, sodium bicarbonate, in the presence of cardiac arrest. It has become evident that less sodium bicarb is needed than had previously been assumed as necessary to provide adequate acid-base control during arrest. Ideally, the drug should always be given according to the results of measurement of arterial pH and PaCO2 and calculation of a base deficit. If such measurements are not available, then, they discussed how you could kind of push certain doses empirically, a 1 milliequivalent per kilogram dose of sodium bicarb followed by half that dose every 10 minutes or so for continued arrest. So we saw that even within 4 years of implementing bicarb within the algorithm, they began to backpedal and say, hold up, we actually know that it might not be good to give bicarb all the time, and that if you do it, you should probably at least have objective evidence of acidosis, right? It should be guided by your ABGs, your labs, whatever, right? So they began to backpedal as soon as 1980. All right, so going into the 1980s and 90s, this was when we kind of were starting to realize that routine use of sodium bicarb is not necessarily a good thing. And it's really interesting to see the history of this because, the cracks in sodium bicarb seem to form pretty early on. But despite this, even, almost 50 years later, we're in the 2026 now, we see bicarb being routinely pushed in arrest all the time. Right. Me personally, I've seen it pushed in, I feel like almost every arrest that I've seen that's lasted more than 5 minutes of CPR, and then I don't think I've been part of a single arrest where bicarb wasn't at least proposed as a therapy or talked about. Right. So the effects of routine use of sodium bicarb have still lingered into today, 30, 40, 50 years later, which is really astounding. And then by 1986, the AHA, or the American Heart Association, reclassified sodium bicarb use from being routine to discretionary. All right, so let's talk a little bit about the science now that we're on the topic here, and why maybe routine administration of sodium bicarb during all arrests wasn't really a good idea. So, number one, let's start with increasing the pH, right? So low pH is bad. Right, causes decreased cardiac contractility, poor response to vasopressors, catecholamines, so we give bicarb to increase the pH and fix these things. Seems reasonable, right? Okay, but let's talk about this. So what happens when we give sodium bicarb? Bicarbonate does raise the pH of the serum. That's without a doubt. It has alkalinizing effects, right? Bicarb plus H plus will turn into carbonic acid, and then carbonic anhydrase will turn it into water and CO2. But does it fix the acidosis? Does it fix the acidic state of the body? Well, that's a little bit less clear, right? We discussed how bicarb can increase your CO2 levels, right? Remember that bicarb is a charged substance. It can't really freely move through cell membranes. But you know what can freely move through cell membranes? CO2. And then when you increase the levels of CO2 in the bloodstream, CO2 can freely move into the cells, right? It'll move into the cells, it'll move into the mitochondria, and it can actually get trapped there. And then when it gets trapped intracellularly, remember that changes the equilibrium. So then the CO2 will be turned back into, right, carbonic acid, and then subsequently be turned into bicarbonate and H+, right? So even though we alkalinize the serum pH with sodium bicarb, the intracellular pH might actually fall, right? So that's very profound. So I'll really hit that home. Sodium bicarb might raise the serum pH. It'll make the ABG look better, but it won't actually affect things intracellularly. And of course, during arrest, there's no way that we can actually, or clinically really, there's no way we can really measure or quantify intracellular pH. Furthermore, the rapid change of pH when you give bicarb in the serum, this is something else that's very interesting. It actually can cause calcium to bind more strongly to albumin, right? Sodium bicarb, especially in high amounts, can precipitate hypocalcemia. And hypocalcemia and these profound electrolyte shifts are also something that we don't like to see. It's not good for cardiac arrest. Let's talk a little bit about the Bohr effect, right? Think back to medical school, the hemoglobin-oxygen dissociation curve, right? What effect does acidosis have on the hemoglobin-oxygen dissociation curve? Acidosis results in a rightward shift. And then this rightward shift of the curve actually facilitates oxygen unloading into hypoxic tissues, right? It facilitates oxygen loading into tissue, right? So there is the potential that our body was designed in these high stress states, right, to have countermeasures in place that can basically counteract the deleterious effects of the acidosis. And one of these is the Bohr effect, where we see that our body is able to better oxygenate our tissues during these stress conditions and during acidosis. So it allows us to unload oxygen into these hypoxic and acidemic tissues. All right. Another thing that we can kind of discuss about acidosis, we already talked about all the bad things that you see with it, but acidosis can actually be protective at the cellular level. During ischemia, cells that are exposed to mild acidosis, so being a pH of 6.8 to 7.1, and granted, these are all primarily lab studies, I think, where they got these from, like in vitro studies. So during ischemia, cells exposed to mild acidosis, they have slower ATP depletion, right? Acidosis reduces enzymatic activity, ATP hydrolysis, and metabolic rate. Okay, this induces almost like a semi-hibernation state of the tissues that can kind of prolong cell survival. We see this in vitro with cardiomyocytes, neurons, hepatocytes, renal tubular cells as well. Okay, during ischemia, cells exposed to mild acidosis show reduced calcium overload, right? Remember that calcium, thinking back to like Rubin's and Robin's pathology, calcium plays a major role in cell death and cell death related pathways. Acidosis can cause has been demonstrated in cardiomyocytes, neurons, skeletal muscle cells, and renal tubular cells to prolong survival. And we see reduced apoptosis and necrosis at the cellular level, right? And if you're interested in the science of this, it's actually pretty interesting. So I don't know if you remember from med school, but there's this thing called the mitochondrial permeability transition pore. This is MPTP, mitochondrial permeability transition pore. And this is one of the big kind of players, this pore, in apoptosis and necrosis related pathways. So essentially what it does is MPTP. It's a non-selective channel that forms in the inner mitochondrial membrane. And then when this big non-selective channel forms, I almost think of it as like it punches a hole in the mitochondrial cell membrane, and it just lets all the ions through. And then by letting all these ions through, it basically disrupts and causes a complete collapse of any membrane potential that was there, right? And our cells need basically membrane potentials in order to conduct basic functions with all of their cellular channels, right? And then what happens with this is basically this will lead to apoptosis if ATP is present, or it leads to necrosis if ATP is present. So MPTP, when that's put in the inner mitochondrial membrane, basically causes cell death. Okay. What we actually see is that in the setting of acidosis, low pH inhibits MPTP opening. Right, so that's big. We see that there is in vitro evidence that acidosis actually has a somewhat protective effect at the cellular level for these cells, at least for this pathway. Right, so acidosis, in summary, can be protective in some situations, especially at the cellular level in low perfusion states like cardiac arrest. Let's talk a little bit about the vasopressor response. Right, so we know that acidosis causes a vasoplegia that reduces the effectiveness of vasopressors as well as catecholamines and raises the defibrillation threshold. Acidosis reduces myocardial contractility, right? We discussed how it can be protective for cell survival at the cellular level, but it causes at the tissue level the myocardium to not function as well and not to beat as strongly, right? Okay, fine. So this is all true. Acidosis could be a very bad thing in these situations, and perhaps even, far more deleterious, of course, than those protective mechanisms that we were discussing before. But here's what I want to hit home. Bicarb does not fix this, right? So bicarb does not fix the vasoplegia that happens with acidosis, and it does not fix the cardiac contractility that happens with acidosis. And in fact, if you're going to talk about, the relationship between acidosis and the increased risk of VFib and VTAC, especially in the setting of myocardial infarction, the increased CO2 load that inevitably happens with the administration of sodium bicarb, remember, a lot of it gets converted to CO2, can arguably increase the irritability of myocardial foci anyway, right? So you get increased arrhythmias just through a different mechanism, right? So acidosis does cause these bad things, but bicarb doesn't fix it. Let's talk a little bit about the cerebral physiology, right? We know that acidosis is overall bad for the brain. Short term, it can be protective, right? It's like turning at the cellular level, acidosis is like turning the brain on low power mode, consumes less energy. It's somewhat protective in ischemic states. So acidosis in the long term is actually bad for the brain. But here's the other thing. CO2, carbon dioxide, is a potent cerebral vasodilator, right? And we know that bicarb administration increases the CO2 in the blood, as we've kind of discussed exhaustively. And this will actually increase intracranial pressure and cerebral blood volume, which can, in theory, worsen cerebral edema post-ROSC, so post-return of spontaneous circulation. So administration of sodium bicarb can cause a degree of cerebral vasodilation, usually due to the increased CO2 levels, and it can worsen cerebral edema. Of course, this doesn't happen in all cases, but at the very least, there is a theoretical and somewhat proven instance of this happening. Next, I want to talk a little bit about sodium, right? You can't give bicarb without sodium, right? It comes with it. The osmolality of our blood is around 290. Osmolarity, I think it technically is. It's around 290. I want to remind you that 1 amp of bicarb, guess what the osmolarity is there? Just in 50 mils, 1 amp. The osmolarity of 1 amp of bicarb is approximately 2,000 milliosms per liter. That's actually equivalent to 6% saline, which, of course, we would never actually give something, but an amp of bicarb has the equivalent osmolality of 6% saline, which is absolutely incredible to imagine. And I want you to think about that osmolar power, right? So if you do, let's say, 4 amps of bicarb, if you put in 4 amps at the same time, it will draw the increased tonicity within the blood will draw water into the bloodstream intravascularly. and essentially dehydrate the surrounding interstitium and surrounding cells, because the water has to come from somewhere. The power of the 4 amps of bicarb, just 200 milliliters, will draw approximately a whole liter of fluid intravascularly. So you really can't underestimate the power of the fluid shifts that you give with even just a few amps of bicarb, literally, right? These rapid osmotic shifts can be very bad for the brain. You can see a lot of hypernatremia, right? Which is also bad for the brain, can cause osmotic demyelination if you raise the sodium too fast and it stays high. So this is another thing. Sodium bicarb affects sodium physiology. It affects the tonicity of blood, sometimes in ways that we don't anticipate and are deleterious. Now, what about ventricular arrhythmias, right? So we talked about how metabolic acidosis does predispose to ventricular arrhythmias, especially after cardiac arrest. Right after cardiac arrest, acidosis has been independently shown to increase risk of VTAC and VFib, right? And these are potentially deadly arrhythmias, very bad. Acidosis can promote electrical instability, right? And animal models even show that an extramyocardial pH below 7.1 impairs cardiac resuscitatability after VFib, and that if you, God forbid, hit a pH of 6.5 or lower, that, there is actually no recovery. So that's like a full stop zone. But here's the interesting thing, and I want to do a little thought experiment with you. Okay. In ARDS, and I kind of got this idea from another podcast called ACRAC, ACCRACC. There was a guy that did a podcast called The Evils of Sodium Bicarb. And, he made this point, which, really resonated with me. And essentially what he talked about was how in acute respiratory distress syndrome, we manage this with permissive hypercapnia. And, the reason, and I'll go on a tangent here, the reason why we do this is because in acute respiratory distress syndrome, there's some sort of insult that's done to the lungs, causes basically diffuse bilateral inflammation, pulmonary edema. The alveoli become very sticky, they become very inflamed, and they overall become very injured. This is a condition that carries a very high mortality rate. It's very severe. We don't have a lot of great treatments for this, but we have about 2 or 3 things that have been shown to be pretty effective in decreasing mortality. And the most important of those things is low tidal volume ventilation. And the reason for that is because we've found in basically trials that we've done with these patients is by causing less barotrauma to the alveoli, by distending them less, by not causing them to open and shut as often, we do less barotrauma, and it allows the alveoli to heal much, much better. And the patients have better outcomes. So a cornerstone of the therapy here is low tidal volume ventilation, and you let these patients get pretty hypercapnic, and as a result, they get pretty acidotic. All right, and routinely in these patients, usually we let the acidosis go down to, usually 7.2, 7.1. And then once it gets down to especially 7.1, the standard of care is to either do bicarb pushes or start a bicarb infusion, basically to correct the acidosis. But I want to kind of point out some interesting stuff here when I was going over the data. So they actually found that in patients with ARDS, in the absence of other stuff like no cardiac arrest, no renal failure, none of that, in patients with just ARDS, when they become hypercapnic and acidotic, they do not show an increased incidence of arrhythmias, despite the known arrhythmogenic effects of acidosis in other populations, right? So this is huge, and maybe it speaks to the more gradual nature of the development of acidosis in ARDS compared to cardiac arrest, right? So for instance, cardiac arrest, you get acidotic within really minutes, whereas ARDS, really you become more acidotic, with the low tidal volume ventilation. It takes, minutes to hours kind of thing. All right, not to mention the underlying cardiac substrate in both cases is different, right? In one case, you have a low perfusion state, cardiac arrest, where, the cardiomyocytes have essentially been starved of oxygen, starved of blood, right? And you don't have the same cardiac substrate that exists in patients with ARDS, right? So they're not very, it's hard to extrapolate between the two. But I think it at least paints an interesting picture of the point that acidosis, at least in the setting of ARDS and, in the setting of it being more gradual, is actually fairly well tolerated by the body. All right. And I want to kind of point out an interesting thing. So, like we said, for ARDS, we give sodium bicarb for pH less than 7.1 because severe metabolic acidosis at this threshold is associated with all sorts of bad things: poor cardiac contractility, hemodynamic instability, resistance to catecholamines, multi-organ dysfunction. But there is no evidence for sodium bicarb in patients with acute respiratory distress syndrome who have a blood pH of less than 7.1 in the absence of acute kidney injury. So I'll stress that as standard of care, we do bicarb routinely in patients that become acidotic with ARDS, especially below 7.1, 7.2, but there is actually very little evidence for us doing that. Decades of human data have failed to show improved survival or neurologic outcomes with routine use of sodium bicarb, and the guidelines are actually updated to reflect this. Now, of course, this doesn't mean that sodium bicarbonate is useless, right? It has its indications, especially in even intracardiac arrest in the setting of TCA overdose, in the setting of acute or chronic renal failure, especially if pre-existing acidosis is suspected, and in the setting of hyperkalemia. But it is not a routine resuscitation drug, even in prolonged cardiac arrest. In medicine, progress often means letting go of things that we were once taught to believe. And I think sodium bicarb is one of those things. And I think it's a good reminder for us as physicians and healthcare providers to just try our best to look at the evidence and do what's best for the patient in front of us, not necessarily try to obtain a perfect laboratory value. With that said, thank you so much for tuning in. I really hope you enjoyed this podcast. Feel free to, like, comment, subscribe, whatever you're allowed to do on the platform. And if you disagree, let me know. I think the beautiful part about medicine is that there's so many different opinions and ways to interpret things. And, we can always learn something new from each other. So thanks so much for watching. And of course, I would like to thank the ACCRAC or ACRAC podcast, episode 24, Evils of Sodium Bicarbonate by Dr. Jed Wopow. They really went over a lot of the same stuff that I did, and they did it before me, and they were a huge inspiration for me to want to do this episode. So huge shout out to them. Please check them out.